respected faculties, delegates, my dear friends. Let me extend my sincere gratitude for giving me a chance to come over in this prestigious Institute of Ayurveda and this conference international. My intention is to share some of my experience, some of my research findings in Panchakarma with my college. It's a direct topic. Snehapana is the prerequisite of all Panchakarma. If it is executed perfectly or scientifically orchestrated, then no meaning in doing Panchakarma or the purification practice. For that purpose, again, before Snehapana, we have to prepare the patient, Deepan Pajan and Dukshan. In Dukshan, what we have done is, different things are there. Usually we give buttermilk, that is completely removed butter in the buttermilk, Chakrapana. So I will just give the scripts of the books, I am not going into details. In a study of 52 patients, we prepared the fresh chakra, butter completely removed. We can add some ginger and all. And as the patient take, as when he needs water or food, only this chakra. And probably possible to go for fasting also. 2 to 7 days they take the buttermilk. So what we observed is the quantity of ghee consumed during Snehapana is very high compared to other group. The butter is not taken for it. And the Samyasnigdha Lakshana we obtain in the 5th day or in the 6th day. But in the other group it goes sometimes 7th day or 8th day. And the complications usually we meet omitting diarrhea in Snehapana. But very negligible level of complications observed in those patients who took butter. And coming to Grida, there is a controversy going on with the plain Grida or the medicated Grida. What we suggested in this study, another study on this 58 patients, what we observed in the plain Grida group, the quantity of Grida consumed is very high compared to the medicated Grida, like Gurulita, Mahadikta and all. And the digestion within a few, 7 hours or observation like that, within 7 hours daily the digestion completed, whereas the medicated Grida more than 9 hours it takes. And for the Samyasnigdha Lakshana, and early, within 5th day or 6th day we get the Samyasnigdha Lakshana compared to the other group. Here also the complications are highly reduced in the plain Grida group. So if you look at the cost of, it's very high. The prepared Grida, they are very high compared to the plain Grida, as well as the taste also. So they recommend plain Grida exclusively for Shodhana type of Snehapana. It is not for Shakti. Then another study about the symptomology. During Snehapana, does the symptoms increases or decreases? There was a 3-arm study. One group it was the plain Grida prepared for the home itself. Other group plain Grida for the market, and other group it was Tikta Grida. What is observed is it was in psoriasis for Shodhana purpose. What is observed is scaling, thickness and redness we took at the clinical symptoms, and the plain Grida group very significantly, highly significantly, all these symptoms aggravated. Whereas the other group, Tikta group, all these symptoms subsided. And the PASI score was the marker. The PASI score also highly increased. That means new rashes came, existing rashes increased. So highly exacerbation is observed in plain Grida group. Whereas in other group it is reduced. Here also we suggest plain Grida for this purification purpose. Then coming to Shamana Snehapana, it is not mandatory to take the same medicine for the entire period of the Snehapana. We have to change the medicine according to the conditions. Another study we undertook, in the ordinary ulcer, 3 Grida we prepared, Indugandha, Tiktaka and Kalyana Grida. So depending on the symptomatology, we start, if ama is there, we start with Indugandha. If burning and pain is, we go for Tiktaga. If both these things subside, we go for the Kalyana Grida to pacify the mental problems. So that was there. Very excellent research. It was a single case design. Once you treat the patient with this Snehabana, it may go for 3 weeks. The next 2-3 years you are missing the patients. That much of result is there. Then we feel castor oil is only for doing some purgation. It is not like that. Ajari is very specific. It has to be used as an analgesic, as a rejuvenating medicine, and the best drug for Vata. That doesn't attain with a single dose of Virejana. So we have done Snehabana with the castor oil. The study is already submitted. Here what we have done now, we start with a very small dose, 5 milli, 10 milli, 50 milli. Likewise, it goes on increasing up to 60-70 milli within a period of 15 days. Early there will be frequency may be increased 4 or 5 times loose will be there. Then later on, patient become accustomed to the procedure and there won't be any problem with the patients. So it was done in low back pain with very excellent result. The VAS is reduced. It is say from 7 point, the VAS came down to 2 point within 15 days. Highly significant results observed. Then coconut oil, a lot of other oils we are using. I'm not going to the details. Then other things, some drugs we know where it is effective, but some drugs we do not know. So we have to explore such a. For example, cotton chukari thaila is meant for external application. We are using it for Snehavana, for Shamana purpose, like all convulsive disorders as well as the carpal tunnel syndrome and all. The study is going on. There is also excellent result is there. Issues are there regarding the paga, regarding the ingredients, regarding the toxicity and all. But beyond all these, patients are getting good result. So we are still continuing these things. Then the question comes about lipid profile. What we observed is, irrespective of the Grida, if the purpose is for Shodhana, then the cholesterol level is coming down on all parameters significantly. The profile also it is coming down. The profile it was insignificant in all parameters. Then if you do it in hypercholesterolemia, then also the total cholesterol level is coming down. See 290 to 193 significant statistically. The LDL, the highly increased LDL also came down with this Snehavana. So it is safe to practice Snehavana in hypercholesterolemia also. Coming to Samyasthita Lakshana, there are 24 items, questions are there to assess the Samyasthita. It is not practically feasible to do all these things. So we tried to develop a proforma for assessing the Samyasthita Lakshana. And we concluded only 5 symptoms are essential to assess the Samyasthita Lakshana. Like Vadanalomia, Deeptagni. That is not to stop Snehavana, but to monitor the Snehavana. Shall we increase or decrease dose? Then coming to Klama, Asamhadavarcha, Adastan Snehadarshana. These 3 things are essential to stop the Snehavana. You need not look into other things. And this Klama should persist after taking the Peya also. Okay, then this questionnaire, the validity, phase validity 90.5, current content validity 76, and very good construct validity, and the excellent criterion validity is there. I recommend we have to take up such basic studies in Panchakarma. Then coming to Vamana, I will just 1 or 2 things all with the numbers. We used to give lot of milk or some Dravadrivi as Agandavana. And into that we put 2 gram or 3 gram of the Vamana Aushadha. It is better you separate it, give it separately, and accordingly we made a little change in the procedure. The morning, the procedure I'm telling, the Abhinga Sweda is there, then give hot water bath, then little Peya with some Girda, ask the patient sit comfortably, then give the medicine. Don't give Agandavana. Give the medicine, let the medicine walk inside, let it go into the Shakha, let it bring the dosha and all. Then when the patient is ready to omit, the nausea is coming, give the Agandavana. That is a very good vehicle for easy evacuation. So we are practicing the same thing. Coming to Virejana, 2 points I mentioned, the time of administration. Our practice, what is our practice? Early morning, by 6:30. What is told in the textbook? It is after Sleshma Kala. Maybe 8:30 or 9:30, 10. It changes according to the region. So this is recommendation. Then our practice, after giving the medicine, we give plenty of lukewarm water for the evacuation. You see, 5 or 10 glasses of water we are giving. What Ajay is telling, what reference is there, it is not at all mandatory. If there is no Vega, if Virejana is not started, then only give water. Apravartetu paye dushma. Okay. why I'm telling, by Virejana doesn't mean elimination of the fecal matter. Virejana means elimination of the Jal Mahabhuta, Rav from the body. So the drug has to draw water content from each and every srodhas or cells, bring it to the kosha and eliminate. That is Virejana. For that purpose, water is needed, but don't give water as such. Let the medicine collect the water. Okay, so there are some recommendations also. We can give little water. Nirbandham pravardhaya. Apravartetu paye dushna. If Veda is not there, if it is not started, give little water. And that water is not to increase the motility. It is not to increase the quantity. It is just to stimulate the medicine. Bheshajya uttejana. That means give very little water to stimulate the medicines. So this is the way. Another study is a 2-arm study. There 50 milli castor oil with 50 milli milk. What is observed is, so early morning, 6 a.m. if you give and give plenty of water, the outcome was below 3 to 7 Vega we got, and 750 milli output was there. Whereas if it is given in by 9:30 or 10, there is no drop of water, maximum 50 or 100 milli. If there is high thirst, the observation around 17 to 24 Vega, that range we got, 24 Vega, and nearly 2 liters also output we got for day. So this is what Virejana is doing. So kindly give Virejana in the Sleshmangala, after Sleshmangala. Coming to drugs, it is high time to ban the castor oil and Ayurveda churma and all. We have to go for specific yoga for specific disease. It is told in Samhitas. Coming to Vasti, per day, same day, how many Vasti we used to give? Only one nirodha. Okay, what is in practice? In practice, what Acharya is telling, up to Sambit nirodha. So we do have the freedom to repeat the Vasti 5 times. Give Vasti, let you pass the stools. Again, you observe the Sambit nirodha lakshana. If Sambit lakshana is not there, repeat the Vasti. Again, give the Vasti. Likewise, up to 5 Vasti we have to give. That is a recommendation. We are not practicing. So we have taken a work on this program also. Low back pain with the Madhurya Vasti. Invariably in all patients, we have got 2 Vasti. Same day, 2 Vasti. First Vasti, observe Samyak Lakshana. In Samyak Lakshana, Slekshma, Kapha Darshana is important. If Kapha Darshana is not there, repeat one more Vasti same day. It's a very excellent result. Patients are very happy with this Vasti. If they are very healthy, you proceed this one. Highly statistically significant results you obtain there. Okay, then regarding the method of mixing, there are different practices. Some people are using mixi, some people are using mortar and pestle. That also we compared mortar and pestle, khaja and mixer methods. What we observed is all the physicochemical and the particle size we analyzed. What will happen is, see the specific gravity and pH. There is no role in mixing methods. All the 3 methods, the same we observed. Then the Briggs index. In the mortar and khaja, there is no difference. Only in the mixture, very high, 10 times increased in this vigor. Likewise, in total soluble also, there is no difference in khaja and mortar. In mixing method, 10 times increased result vigor. So what does it mean? Usually when we mix the medicine, then we go for we filter it. In the filtrate, we get the same quantity of kalka. 30 gram Shadapushpa you take in the kalka, then you filter, the 30 gram comes in the filtrate. So the actual medicine is not coming into the ingredient. So better go for mixing method. Only problem is Phena dosha is there. Lot of froth is coming. So particle size also very huge difference observed. In khaja it is 134, whereas mixer it is 1320. Still we are not in a position to say which exactly we require. We need smallest particle size, but this study is very big. So coming to Nasya, only one point regarding the dosage. This is the practice what we the reference in textbook 6 Bindu. But our practice is drops. What is 1 drop is 0.04. If you take 10 drops, our Nasya is below 0.5 milli. That means even half milli is not used for Nasya. So we have done a work on this and we finalized 1 Bindu is half milli. If 1 bindu is half milli, 5 milli, 3 milli, 4 milli is the actual dosage. Accordingly, we have taken a work on corpuscular saline avobaqua. What we observed, the conventional group 6 drops and the trial group it was 3 milli. 3 milli 2 times we installed, 1.5 milli, 1.5 milli in both nostrils. There also, see, in WAS, 75% of high reduction observed in the trial group. And in the disability index, 69% of increased result will be got compared to traditional practice. And in Samyak Lakshana also, in the traditional practice, nothing we are observing. But in the increased dose, it is observed. So, let me conclude. What I told is what we are practicing. We need some change in the procedures. Lot of procedure errors we are committing. Try to change it. So, be sincere to science. Do justice to Ayurveda. We are talking a lot about Ayurveda, national and international level. So, once again, think back and do justice. The procedure this should be avoided. So, try to practice Panchakarma classically. So, the system will be saved. Thank you.
I would like to ask you, did I understand it correctly, that you make more than 1 basti per day? And what is the time distance? Is it do it in the same treatment, or do you wait some minutes and then you make another basti?
So, you prepare basti, actually the reference is we have to prepare a large quantity. So first, suppose we decide 500 milli one patient, we have to prepare 1 or 2 liters. From that 2 liters, take 500 milli, do the basti, and let the patient go to the toilet, then evacuate. Then we observe what is the content. If kapha is there, kapha darshana is there, it's okay, fine. They need not repeat it. If kapha darshana is not there, immediately give the next basti. That is the practice. That is told in the classic samsara.
And what's the maximum of bastis you can do per day?
Quantity you are saying. Quantity. Number of
times.
No, in reference, if you go into the classics, there is a freedom for 5 basti. But in the study, we tried only 2. We will first study. 2 bastis we heard. We are in samples, it's 130 patients we tried. Now it is a practice. It is going on. Very excellent result is there.
What happens if you make corporal lavage? You know the system of corporal lavage. Yes, you wash out the colon with a fluid, and you take the fluids for vasti, yes, and you use it to make the corporal lavage. What happens? Is there a difference between these people you treat with classical vasti or with corporal lavage? You know what's corporal lavage? You have a machine.
Colon therapy.
Colon therapy.
Yes.
And for
water in it.
That we have not tried. But the basti is safe, we are practicing. We do have the confidence.
But could you imagine if we make this corporal lavage, we wash out the colon? Could it have the same effect, or is there a difference in this?
My personal feeling, no. Actually, what is basti, what is not basti? That is the question I feel. Basti doesn't mean elimination of some fecal matter from the body, from the colon. Nothing to do with the collected fecal matter in the large intestine. Basti is not interested in that area, because basti has to be done after region only. So it's a site of action is in each and every cell, like our Srodhas, in the millions and millions of Srodhas are there. Basti has to act at that level. Then only basti acts. All the wash, colon wash, stomach wash, that doesn't comes under the purview of Panchakarma. Panchakarma is entirely different. It's a purely scientific thing. That actually is beyond our imagination. Niruha means it's beyond our imagination. It happens. So
but at the end, you believe that you influence the colon by basti or not? Do you influence more than the colon?
Yeah, sure. That is the only approaching area is the colon. But the effect is beyond that colon.
Yes, that's true. That I've explained to you. Yes, the colon-brain axis. Yes, you have a lot of steps. Yes.
Definitely. We'll try, sir. This colon wash we'll do for a comparative study. We'll do it.
We have it in our hospital, but I wanted to ask you whether you see a difference between these 2 methods. For us, I guess it's much easier to make colon lavage because we can do it at every time in the day. And our doctors in Germany, they apply basti only around the midday time, yes, before lunch. So I don't know, when do you apply basti? Also in the evening or in the night? Or
usually we do before lunch by 11, 10:30, 11.
That's what we are doing at the moment also in our hospital, yes. And then that is limited if our staff can only work in this time fasting, yes. And you know, a modern hospital needs 8 hours treatment possibilities, yes.
But sir, there's a big recommendation how to do severe, follow it.
You said that it relieves shoulder pain.
Yeah.
And what criteria you have diagnosed shoulder pain?
Criteria.
Yes. Majority of our population, they have shoulder pain because of diabetes uncontrolled.
Yeah.
If the diabetes is controlled, automatically the shoulder pain goes off.
Yeah.
So what are the diagnostic modalities you observe in this case of shoulder pain?
I'll tell you, in this study, diabetes was there in the exclusion criteria.
Exclusion.
None of the patients were diabetic.
Is it due to injury, shoulder pain due to injury?
It is basically a cervical spondylitis. It's
That's
not
a referred pain. That's a referred
Yeah,
pain.
referred pain. Yeah. It's
As
not a
such,
local problem of the shoulder.
A local problem. You can have, suppose in modern trend, you can have a magnetic resonance MRI. Whereas you can diagnose what is the reason, what is the muscle involved. That we can do all these things. And we can do this. We can address adhesive capsulitis as it happens in other diabetes also. So what is the modalities of diagnosis? What is
I understood. Thank you, sir. Suggestion. That much of invasive diagnostic tools are not being used. It's a routine dissertation work of the student. Then we follow it. Definitely, for the study we will include all this.
Thank you.
You speak about shoulder pain, is it an acute pain or a chronic pain?
Chronic pain.
If you speak about chronic pain, you can also believe that it's a conditioned pain, and the pain is not in the origin, is not in the shoulder, but is in the brain. Yes, because the pain receptors, they tell to you the pain is in the brain. Then you have to treat the brain, not the shoulder.
It was in the cervical region.
It's the same. For example, if you lost a limb, yes, a feet in the war, and you have the pain you have in the feet, but you have no more feet, yes, but it is a brain pain, chronic pain. It's different from the acute pain.
Thank you.